This video demonstrates how nurses can work with families of hospitalized dementia patients to identify normal behavior patterns and individual preferences, as well as actively involve families in planning for care and for return to home, with an ultimate goal of preventing problems and improving outcomes.
Mr. Patel is a 71-year-old Indian-American man. He came in this morning for pre-admission testing for a right knee replacement. He has a significant history of pneumonia. He's been hospitalized for that twice, and he was diagnosed with probable Alzheimer's disease last year. The daughter shared that he has had a full medical workup and goes to a memory clinic for his AD.
I am here.
You're going to have surgery, so we came here a few days earlier so that we can talk to the nurses about what you need to do. You're going to get some testing done. Okay?
Oh. How will I go home?
You will. Yeah, you'll be able to go home, and I'm going to be with you. You just came in for some testing, that's all, before the surgery.
Oh. Why am I here?
We're just going to answer some questions, meet the nurse, fill out some forms, and you're going to get some tests done. I'll be with you. It'll be okay. All right?
Okay.
Hi, how are you today?
Good, how are you?
Hi, I'm Karen Hirschman. How are you? Nice to meet you, Mr. Patel. Hi, Ms. Patel. How are you doing?
Good.
This
Nice to
is
meet you.
Therese Stollard.
Nice
She's
to
our
meet you,
nursing
Mr.
student.
Patel.
Do you take this?
Nice to meet you,
Nice
Ms.
to
Patel.
meet you. We're going to talk a little bit today about some of the testing you're going to have done and maybe some paperwork that we need to fill out, okay? So, how are you feeling today?
I don't know.
Okay.
I don't know why I'm here.
You're here today for some pre-admission testing for surgical procedure you're going to have, and I'm going to meet with your daughter after you go out for the testing, and she and I are going to go over some paperwork with Ms. Stollard, and we'll fill out those forms, and we'll come back and go over the forms with you again after you've had a chance to look over the paperwork.
Okay, sounds good.
Here you go.
Thank you.
All right, so someone will be here soon to take you for some testing, and then we'll come back and meet with you. Okay?
Okay, great.
Great. Thanks.
Thank you.
We ask that all family members, when they come in for pre-admission testing, fill in this paperwork. It helps us to get a better understanding of where our elders are at, or our patients are at prior to coming in for their testing.
Okay.
In particular, since your father has some cognitive impairment, specifically he's been diagnosed with Alzheimer's disease in the past year,
Yes.
we're very interested in getting an understanding of what his baseline is like. Think about the last 1 to 2 weeks. To truly understand what he's like, we need to know what his baseline has been like for the past 1 to 2 weeks.
Okay.
So let's go through this form and we can talk about some of the answers to these questions and go through them. But we really need to understand the details of this so that we can better prepare for his hospital stay after he has a surgical procedure.
Okay.
Okay. So, how does your father prefer to be called? Should we call him by his first name?
My dad's pretty formal, so I think if you refer to him as Mr. Patel, that would probably be better.
Okay, great. So we'll call him Mr. Patel. Good to know. And is it accurate that you live with your father? Is that correct?
That's correct, yes.
Okay, and you're his daughter, obviously.
Yes. I moved in
Established.
with him a few years back when he started having a little more trouble.
Okay, and so what are some of the things that you do with your father that are you able to help? You said he's having some trouble. So what are some of the things he has troubles with?
He does need some assistance with getting up. He's, in a wheelchair, so getting him into the wheelchair, transferring to a chair maybe. To the bathroom, he needs assistance with that.
And
Things like that. Yeah.
Oh, okay. And when you're at home, is he able to get around the house with minimal assistance, or can he use the furniture? Does he use a cane or a walker?
He does use a cane. He does need some assistance. Once again, he's he can get around, but helping him in and out of chairs. He's, a little bit unstable, so it's probably more me being a little nervous around him, just making sure he's okay.
Okay, so has he had any falls recently?
No, he has not.
Okay, so he hasn't fallen. Okay, that's good to know. So let's think about some of the other things. And a lot of these questions that are on this form are really about his activities of daily living, so things he may or may not need assistance with. So the things I just asked you about are about how steady is he on his feet, is he able to walk and transfer from seats to standing and so forth. And so some of the other questions that we have are really about his eating. So while he's here, we're going to be providing him with meals.
Right.
We need to know what is going to work best for him. So does he, what are the things that he likes to drink? Does he...
I've tried to get him to drink juice and other things, but he primarily drinks water and Indian style tea. So
Okay. Does he need a straw to drink? Is he usually able to drink from a glass?
Usually from a glass, and he doesn't use a straw.
Does he use dentures or?
No, he doesn't.
Okay. So does he have all of his teeth?
Yes, he does.
Okay. So he doesn't use dentures. Good to know. And what other foods does he like to eat?
Well, he's vegetarian, and he usually eats Indian food for the most part. So vegetables and lentils, rice, Indian bread.
Okay. Is there anything he doesn't eat?
No. I mean, he doesn't have a lot of dairy in his diet, maybe a glass of milk. That's about it. But for the most part, a vegetarian diet.
All right, so let's think about his eating. When you set him up, when you prepare his food, do you have to set him up at the table with all of his utensils and his plate and everything?
Right, and I usually will cut up the food into smaller portions for him, and then after that he's able to eat on his own. Yeah.
Great, okay, so that's good to know that needs a little bit of assistance.
Yeah.
All right. Does he wear glasses? I saw that when he came in. Does he need those to read?
Yes, he does.
Does he need those to see at a distance as well? Okay, so does he have bifocals?
He does have bifocals, yes.
All right. So he's going to need those while he is here.
Right.
All right. Does he wear a hearing aid? Anything
No,
like that?
not at this time.
So his hearing is okay at this point? All right. Now, tell me a little bit about your background, if you don't mind.
Sure.
Your father has a slight accent. Obviously, he speaks English. He spoke English very clearly.
Right.
Does he speak any other languages?
He does. I mean, I speak to him in English, and he speaks to most of our family members in English. But he also speaks Hindi and Sindhi, and more with his colleagues or people of his own age group, he'll revert back to his native language.
Okay, but he does understand English. Doesn't have any difficulty with it.
No, he doesn't.
Okay. And is he able to convey his needs? So if he's hungry or if he's uncomfortable or if he needs to go to the bathroom?
Right. Yeah, he usually can tell me what he needs. If he has to go to the bathroom, he will let me know, but I will usually walk with him and help him out of the chair and get him over to the bathroom. But then after that, he can handle things on his own. So.
Just thinking about that, in the past 1 to 2 weeks, has he had any accidents or have there been any problems with getting him to the bathroom or him letting you know that he has to go?
No. But once again, he's somewhat unstable on his feet, so he does need a little assistance.
Okay. So what other things does he need a little assistance? Is he able to, if you were to set him up in the bathroom, is he able to wash his face, brush his teeth?
Yeah, so he's able to do that. Some assistance with dressing, once again.
Okay.
So that would be pretty much the main place that I would help him with, or the home health aide would help.
Okay.
But he's okay to brush his teeth and
All right.
wash up.
So if your father was experiencing pain, which he might after this surgery, the likelihood is pretty good that he's going to have some pain after the surgery and he's going to get some pain medication. Is he going to be able to, or how does he express pain?
Well, he's not going to complain or tell you that he's in pain. You can probably tell from his facial expressions more than anything else. It'll be nonverbal.
When he gets anxious or upset about something, how does he react?
He's pretty quiet and withdrawn. He won't engage as much as he normally would.
Okay. So do you think he sort of shuts down, be sort
Right.
of nonverbal? Or
Right, that's exactly.
what helps to calm him down or comfort him in difficult times?
My father's pretty religious, so any type of religious music would be helpful. That does soothe him. He will read passages from his scriptures that can calm him down.
Okay. And does your father usually watch TV?
Not a lot. He does watch religious related channels and the news, but he won't sit and watch a movie or a sitcom or anything like that.
Okay. And you mentioned he likes to listen to music.
Yes.
So, would he listen to the radio?
No, mostly his religious tapes. Those are the types of things he would be listening to.
Maybe having some of that music here would be helpful. So
Yeah.
maybe we could, if you'd be willing, we could sort of talk about bringing in a tape recorder that has that music, or a CD player or something
Okay,
like
yeah,
that.
I think that would
We
be
can
helpful.
Work together on that. Does your father have an advance directive?
No, he doesn't.
Doesn't have one. Okay. Is that are you the person who makes the medical decisions for him?
Primarily, me and my sister do that together.
Okay. And is she going to be available for this hospitalization?
She will. She will.
Okay.
I'm primarily the one that will be there for the majority of the time because I'm local and I live with him.
Okay. And are you going to be coming to the hospital every day?
Yes.
Okay. Will you be here all day, or are you going to be going to work and then coming in the evening?
Probably coming in the evening. The first day I'll probably be there all day, and then I'll come in the evening after that.
Okay. Great. And it looks like we have your cell phone number.
Yeah.
We've put
Yeah, I
that
think
down, so we
everything's
can
on here.
certainly, we know how to contact you if we
Okay.
have any questions. Is there anything we haven't asked about that you want to tell us about for your dad?
My dad asks a lot of questions. I think he likes to know and have information, and actually that's usually when I can tell he's a little withdrawn because he won't ask as many questions.
Okay. Are these, repetitive questions, the same thing over and over?
At times, yes, they can be repetitive.
Okay. Is there anything else that you or your family want to know from the physicians or from the providers that are going to be caring for him?
Well, I have two concerns. One, I'm a little worried about how he reacted during his last hospital stay when he had pneumonia. He was very confused and out of sorts. He had some agitation. He kept trying to get out of bed.
So he seemed more confused. Did it resolve itself? Did it go away?
It did go away, yes.
Did they say that he was experiencing something called delirium?
Yes, exactly. That's what
Okay,
they
so
said.
he had experienced delirium during his hospital stay?
Right.
And then it resolved itself?
Yes.
Okay, well, that's something we certainly would, we're going to have to look into in terms of thinking about how we want to develop his care plan with the rest of the team. Do you have any other questions for the providers?
I'm just concerned about what will happen when he goes home and when he's discharged. That's just a concern.
Okay. We're going to be having a team meeting later this afternoon. Are you going to be around? We'd love for you to be a part of that meeting, talk about what the care plan is going to be for your father while he's here, and we will definitely address the concerns that you've raised about delirium and his confusion. We will put that into the care plan and figure out ways that we can manage that and try and avoid that with this hospital stay.
Okay, yeah, no, I'll be there.
And also we'll talk about, as we always do, planning for his discharge and what's going to happen.
Okay, that sounds good.
Okay, great.
Thank you.
So, Therese, what did you think about the interview with Ms. Patel?
Well, the manner in which you conducted the interview, is that how you normally conduct it? Are there other ways you could go about doing it?
Sure. In this situation, it's ideal. This is a pre-admission setting. We know the individual is coming in for a hospitalization. Mm-hmm. We know in advance that they have a diagnosis of Alzheimer's disease. And in this case, the family is available, and so we were able to sit down and go through the form with them. We don't always have the time to do that. And because of that, this form can be used in a couple of different ways. When a patient's hospitalized, where we can actually hand the form to the family member or someone who's close enough to the elder to get that information from them and then go back and review it with them. Nursing staff or social work staff aren't always going to have the time to sit down like we did with Ms. Patel. This form could be used over the phone if a family member can't get into the hospital, which is sometimes the case if a spouse is just as ill.
Ms. Patel seems very concerned about her father, so is this normally the case?
It really varies. It's great to see that this family member is so involved, but not everyone has a family member that is that involved, or even just having someone, period, whether it's a neighbor or some other person who can help them on a regular basis. So we don't always have someone who's available to us to ask these questions. And in those cases, we have to make the assessment ourselves. And or if the patient is capable, to ask them for as much information as possible and make more observations of them and sort of assess what their baseline is.
How will you use this information from the tool?
The goal of the tool is for us to improve care and outcomes for this patient and their family members, and to get the family involved in care as much as possible. Many family members want to know about what's going to happen. They're anxious. This is if it's an unexpected hospitalization, they don't know what the outcomes are going to be. They don't know where their relative is going to wind up, if they're going to be able to come home. And we need to know up front from them where the patient is in terms of their baseline. And so using this tool helps to bring them in on a level of getting more information from them and getting them involved in the care. Thank you all for coming to the team meeting today. Appreciate it that you were able to be here. We did the assessment this morning with his daughter, and we went over a number of things using the tool and found some significant things that I wanted the team to take into account when we put his care plan together today. So in particular, she, as I mentioned before, she said that he did experience delirium during his last hospitalization. She was very concerned about that and wanted us to talk about that today, and she will be coming to our meeting after we've put the plan together to talk about the findings. He also, because he's coming in for a right knee replacement, we're going to need to look at a falls risk and look at that.
Does he wear a hearing aid or use glasses?
No, in the assessment he does wear glasses.
Okay.
He wears them to read and for distance, so he does have bifocals. His hearing is intact and does not wear hearing aids.
As I'm thinking about ways to prevent his delirium in the hospital, so one thing to think about as a risk factor for delirium is, one is cognitive impairment, but also any other sensory impairment that he may have. So the fact that he wears glasses is really important for our team to know, because we want to make sure that he has those available to him after or throughout the whole hospitalization, really. When you come in the hospital, your whole sleep-wake cycle is disturbed, and that can be a risk factor for delirium. So we have to make sure that during the day his room is well lit, and that at night it's a peaceful environment. Some other things we can think about post-operations. So one would be to make sure that his hydration status is normal. So we'll make sure we check his eyes and nose on the chart. And also getting someone out of bed and into an early ambulation protocol. So he's post a knee replacement, so we'll have to get the physical therapists and the surgeons to help us out with that plan, but we should probably keep that in the back of our minds as well. And then lastly is the pain assessment, which Karen brought up. This can be really important because untreated pain can be a risk factor for delirium, and that's probably one big one we should think about. So, Brian, what would you suggest for his pain assessment, given his history?
Well, they should frequently, more frequently than normal, they should frequently assess him for any kind of pain, make sure that he isn't having any grimacing, and also use one of the facial scales or a scale, a numeric scale, to try and have him gauge the level of pain, and also to make sure that we try and preempt any pain development, so that to offer analgesics early and often, so that the person doesn't have pain get ahead of them, necessarily being in pain.
There's been data showing that patients with dementia who are admitted for hip fractures aren't given a scheduled pain medicine, rather they're given a PRN med. And you can imagine with this guy, given what Karen tells us, he may not ask for a pain medicine. So scheduling a pain medicine, offering, and he can refuse it, might be a better protocol than just simply having a PRN or as a patient requested need. So I like that plan a lot, and using different tools and finding out which tool works best for him. So start with a numeric, but if he doesn't quite comprehend that, then the FACES pain scale would probably be the next best choice. So I think that's a great plan.
How do we know if Mr. Patel develops delirium?
There are several validated instruments we can use, but the best studied is called the CAM, or the Confusion Assessment Method. And it's an instrument that you can use on a repeated basis on the same patient, both in inpatient setting, ICU settings, and outpatient settings, to determine if someone is delirious.
How often would we use this tool?
Typically, the nurses will administer it once a shift or every 8 hours, or with any change in level of consciousness or any change in condition.
Okay.
So I think the last thing that we need to talk about then is the issue of falls, and that he's at risk for falls. He hasn't had any falls recently. However, he does use a cane, needs some contact assistance to get around, and now that he's had his right knee replaced, we're going to need to put a plan in place, especially with the risk of delirium for this patient and his pain issues, potential pain issues, I should say. So, Brian, do you have any suggestions on how we can plan that?
Typically, what we will do is implement a modified protocol, keep his bed in a low position at all times, side rails down as much as possible, with everything within reach, especially any assistive devices such as his cane, the call bell, and also have the nurses check in frequently to make sure that his needs are met.
The other thing I was thinking about to add to that is we can make sure to review his medications for medications that are known to be fall risks. So Therese, like benzodiazepines is a really important group of medicines to avoid in older adults who you think are at risk for falls. So we'll try to limit those for that reason, and also because they may worsen delirium.
So it sounds like we have the plan together for while he's here. And I think that we should bring his daughter in, and I know she's waiting for us to talk about his plan of care while he's here. I know that she's going to be interested to know what's going to happen afterwards. That was one of the things that she brought up when we did our evaluation that she was concerned about. Hi, Ms. Patel. It's good to see you again. We just wanted to say thank you for coming, and glad you could be here today with us to talk to, allowing us to get to talk with you as a team. So there were 3 things, and one of the things you've brought up is your concern about his developing confusion again, developing delirium while he's hospitalized. So we are putting in place a delirium prevention plan, and we can tell you more about that.
Okay.
We're also going to put in a plan for pain assessment. I think that's important for us to talk with you and for you to tell us and communicate to us if you see your father in pain, if he doesn't communicate that to us. But we are putting in a plan where we're going to routinely assess his pain. The last item that we're concerned about is keeping him safe and not falling. He is at risk for having falls because of the surgery, because of his dementia history, and because of the medications he's going to be on. So our nursing team will put into place a falls assessment and specific things to keep him safe. But if you do see any changes in his behavior, in his demeanor, anything that seems a little out of source essentially for your father, anything you're concerned about, that you aren't afraid to tell us about that because you know him best and you're able to tell us what he is like. We may not see all those little nuances about your dad that you know better than we do.
I just want to say that it's really reassuring to hear that you have all these plans in place and that you're going to be spending so much time and paying so much attention to my dad's needs. That really means a lot to me, and it's very reassuring.
The current exact figures as to how many patients or the percentages of patients who have a diagnosis of dementia who are hospitalized is unknown. We don't know those exact figures, but on average, they estimate that there are approximately 25% of those who are 65 and older who are hospitalized who have dementia. For those with dementia, there are some risks for them. They're at higher risk for developing delirium. They're at higher risk for becoming deconditioned or having decrease in their functioning while they're hospitalized. There are problems that can occur with continence. There are problems that can occur with a variety of their basic activities of daily living. They often have untreated pain and are at higher risk for falls. This tool allows for family members to get involved in the care of their relative while they're hospitalized. It allows the providers to get a better understanding of what's going on with that patient, where they were 1 to 2 weeks prior to their hospitalization. It allows us to get a sense and an understanding of where they are at and how we can bring them back to that same level of functioning. And if that level of functioning changes over time, if while they're hospitalized we see a difference from what they said was at baseline, we can get on top of that early and as soon as possible. And this tool allows us to get at some of these features, so knowing how a patient communicates, knowing how a patient is able to provide information or their behavior when they become agitated or when they become uncomfortable, such as when they experience pain. We can use this tool to help us to better identify that with this population. They're also, among this population, they're higher risk for deconditioning. And again, going back to their level of functioning, when we know up front what their level of functioning is, we can try and bring them back to that level of functioning, or at least help to prepare the family moving forward to help them to get back to that level of functioning. Family members benefit from the use of this tool, in our opinion, by getting them more involved in care. This allows the family member who is 300 miles away or the family members that's at the bedside to be able to provide information about their relative to the best of their knowledge to help us then to provide better care. Plus, we can then use this tool in our care planning to then take this information back to the family. So if they're concerned about something, if they've identified that this person has problems with behavior or has difficulties communicating, we can then take that information, put it into our plan of care and how to provide the best care for this patient and their family, and bring the family in to that planning process in a much more personal way than without them involved. Now, best practices say that we should be doing that anyway, and in many ways we are doing that. This tool just allows us to formalize it in a way and provides nurses, social workers, and other types of providers with a tool to be able to get at the key questions for this population of elders with cognitive impairment and dementia. This assessment should be done as soon as possible. So if a patient has been admitted to the hospital, the sooner the better. The sooner you get the information and knowing where the patient was prior to the admission in terms of their level of functioning, behavior, ability, and other abilities, the better in terms of being able to then assess where they're at now in terms of level of functioning and moving forward, what they're going to be capable of doing. It's very important to explain to the family why we're using this tool with them and why they're being asked to either fill it out or we're asking them these questions. In particular, it's important to let them know that their feedback, they're the key informants. They know their relative best in most cases, to provide that information to us so that we can improve care. That information will then be, from the tool, will be provided to all the providers working on their relative's case and helping them with their care. So one of the other benefits to using this form with family members is that it provides us with a variety of areas of information, and we can often delve into other aspects of it that with the family member, they may provide us with information that we didn't know was there. So they may tell us that the patient had a history of falls that wasn't available to us in another form. That information didn't get to us otherwise. They may tell us about a previous medical or a history or a hospitalization where something happened that isn't available to us in other information, and that this tool can be our way of launching or jumping off into other conversations and to gather more information to help us to plan for the care of this elder. Some of the challenges in using this tool are that we need to be sensitive in how we ask some of these questions or how we probe some of these questions. There may be cultural issues, they may be ethnicity questions, things that you need more information about that this tool will allow you to get at sort of the surface of, but that you're going to need to be somewhat sensitive about. There may be cultural differences. For example, you may be asking about how someone feeds or how someone eats, and there may be cultural underpinnings there. There may be something going on there that you need to know about. Like the daughter always prepares the food for the father. He doesn't cook. It may be that, he eats with his hands because that's what culturally he does. This tool can be used with patients at all stages of their dementia. This isn't just for patients who are still highly functioning in terms of their activities of daily living. This is a tool that can be used with family members to get a good sense from the family's perspective of what they think their relative is capable of. And then it allows the providers to then make an assessment of what they think that the patient is truly capable of. And this can be used for patients who are in the early stages of cognitive impairment and dementias such as Alzheimer's disease, or in the later stages of the disease, more advanced, where they're unable to feed themselves, they're not walking, they may be bedridden, and may not be verbal, may not be able to communicate. So this tool does allow you to get at both ends of the spectrum and all the places in between.